surrounding sur- there is some surrounding mass effect into the basal ganglia also was noted. The hematoma was big in the basifrontal region. And there is also, we can see in that right side vitreous, we can see that hemorrhage is noted. It's a part of the Terson syndrome. So, CT angio was done, which showed a wide neck aneurysm involving the right ICA bifurcation, projecting superiorly, and there was a small doctor sac was noted at the dome, which was the site of the bleed. So, patient was stabilized with the anti-edema measures, and patient was taken up for the DSA. In the DSA, it is in a right ICA, APN lateral. We can see the wide neck right ICA bifurcation aneurysm with the neck of the aneurysm incorporating the right A1 ACA. This is the run from the left ICA with not much contribution from the left side to the ACOM. Here you can see the 3D. The aneurysm is wide neck and neck of the aneurysm incorporating the A1 ACA and superiorly directed, and this small doctor sac which is site of the probable site of bleed. So the neck was measuring around 4.4 mm, and the dome height was 9.8, and the dome width was around came around 8 mm. So the treatment options which are planned are possible treatment option in this cases are balloon coiling if plus or minus 10 as a backup, or partial coiling of the dome followed by the interval FD, stent tested coiling, flow diverter with the coiling, and the possibilities like intrasaccular devices in the form of web or scaffolding devices like Trenza with the coils. This patient was not much affordable, and they are not in a very keen on to follow up. So, uh, we what we planned was Trenza with the coiling. When this case come before 1 week before itself, before 1 week of this case only, Trenza was launched in Chennai. The why we chosen this case was with the Trenza was balloon. It was a very big aneurysm, so even of the balloon inflation, even cannot be protected, and we may have to give multiple coils, and other thing he may have to be in a follow for immediate follow with a secondary treatment may be needed. And it's because of the high thick bleed, patient can go for may need a further neurosurgical intervention. So we avoided stent and FD. So we have gone through the Trenza with coils. We will go on see the what is the Trenza device. So it was from the striker neurovascular. So it is an intrasaccular scaffolding device for the treatment of the broad range of wide neck aneurysm. So it will allows the stability at the level of the neck, and it won't be projecting into the parent artery. So what is Trenza is it is nothing but the it is thicker type of coils. It made up of braid, which is 24 wire braided coils. So it will be mechanism of action is volumetric filling. So it is just this representation. We can see that so the devices consist of a distal one coil, which is a normal simple coil with a detachable coil, which is one that is comes around 3 mm. Then followed by that this Trenza device, which is a braided material, will be there, and distal. Then again the proximal detachable tip will be there. So this is the configuration. So distal tip will be there, that length around 6 to 14 mm. Then followed by braided material, which is of 24 wire braided material with the DFT technology. then proximal end, which is having attached to that end of the braided material. So it is compared to the normal detachable coil, it is having 3.5 times that of the width and 1.4 times that of the packing densities. So the available sizes are 6 to 12 sizes with the fixed length in the each subgroups. So totally 7 available lengths are there. So available sizes are there. So it is delivered through the Excelsior 118 catheter, which is actually having 019 ID. It is 0.02 ID bigger than that of the normally used coiling catheters. So similar to any other coiling catheter, it has two markers with additional support for the delivery of the system. So when the available with the if we are using the distal access catheter, we have to know the profile of this with the additional coils and so additional coiling catheter or balloon. If we are using additional coiling catheter like SL10 or SL1 or headway, we need to have 6F guiding system of DAC. So either 6F Navion or vector 71 or DAC distal access catheter. If you want to use the this Excelsior 18 catheter along with that balloon, we may need to have vector 74, which is more than 170. This one is needed. Otherwise, we can directly take from the guiding catheter and we can use the two systems. So the sizing is depends upon the width of the aneurysm, dome width, and the dome height divided by 2. So if it is comes around 8, we can choose just at the same size or slightly 0.5 0.5 increase in the size. So for aneurysm, it's ranging from 6 to 8 we are using only one or we can use only one Trenza. If it is more than 9 we can, if are possible, we can use a second Trenza device also. So if it is oversized, what will happen is a higher degree of the paint pressing and the coin like stacking like appearance will come. And distal end of the distal end will be pushed out of the neck. Undersized means again it will cause the frame visibility smaller and the adequate neck production won't be happening. So when we are using the Trenza device, we need to keep on this one. This the distal coil, which is allowing initial support to form the shape. It should be away from the neck of the aneurysm, because when we are forming the final shape, that distal tip should be away from the dome, away from the neck. Because when we are doing subsequent coiling, it should not come out, and it is nothing but the coil only, but it should be away from the neck. Second one is there should be adequate loop of braids should be there at the level of the neck. Minimum 2-3 loops should be there at the level of the neck. And when we are detaching, we will be having two markers. One is the proximal, that detachable proximal end of that braid, and another is detachable marker. Both markers should be visible when we are detaching, and that proximal one should be away from that proximal end of the coiling catheter. So if we are not seeing properly and detaching this end with this one, and a significant amount of this distal end will be there inside, and it will be difficult to push inside. And that our Excelsior micro catheter should be in the proximal 1/3, so that it will allow the adequate forming of the shape. The shape which is formed is omega shape, so that 2 to 3 loops will be there around the neck of the aneurysm. So whatever available the same micro catheter can be used for the coils. For the striker coils, same this 10 coils will be compatible with the same catheter. There won't be any coiling at the level of the hub won't be happening with the same target coils. So if we are not when we are forming the shape, if that distal marker is at the level of the neck, we have to again rearrange in a such a way that it should be away from the neck. When we are realigning, when we are realigning, uh, so when you are retrieving the Trenza device, you should be very careful that it should be the tension and all should be relieved. And when we are retrieving, it should be level at the level of the neck with the junction with the aneurysm, because to allow the retrieval of the Trenza device safely. Otherwise, it will cause uh, an uneventful detachment, or it can cause a uh, uh, it can be projected into the parent artery also. So so same microcatheters can be used for the coils. So this is the only one thing we should remember is the width of the available sizes from the 6 to 12. So width of the aneurysm at least should be 6, or the mean average of the width should be 6 mm. It is preferable to use in a dome neck ratio of 1.2. And if it is like this, a bifurcation aneurysm symmetrically wide neck, it is a preferable case. Slightly offset or slightly irregular aneurysms, it can be tried only if you are well versed with the few cases with the Trenza. Sidewall aneurysms or irregular aneurysm needs a good handful experience before testing these complex aneurysms. So, and another thing is we no need to pack the neck very tightly, because over the period of time that neck residual filling can go off its own. So in our come to our case, the aneurysm width was around 8 and height was around 9. So we have chosen a 9 mm 9 mm Trenza device. So 9 into 16 mm was used. So our material which are used are 8F series base guiding catheter. We used a distal access catheter, Vector 71. We kept a SL10 as a backup. We coiled with the same Excelsior 18 micro catheter. So, so this is the shape initially formed. When you are initially deploying, we kept that micro catheter in a very taut position, so it didn't form the omega shape. So it is what called the coin stacking. So it won't support the neck adequately. We have to allow the proper shape to form. Here we can see that this distal coil marker is away from the neck, so it was an adequate position, and both marker this marker is very well visible. So we detached, and subsequently we have coiled with the 6 micro coil. In pack the neck too much, because we don't have the balloon at this level, and we wanted A1 to flow very well. Uh, for this patient, we actually, though we are not no need of antiplatelets, we initially loaded with the ecosprin and cloplet loading dose. Followed by 3 days, we continued on ecosprin. So this was the post procedure day one CT, not much ischemic complication was noted. Patient had a right eye visual blurring, which was improving over the period of time. And the patient started on physiotherapy in view of left-sided weakness, discharged and sent to rehab center. At the 1 month follow-up over the telephonic conversation, patient now in rehab center near to his home. He was walking unassisted, but his hand weakness is still there. It needs to be improved over the period of time. So there is not much evidence, not much data on this Trenza device. This is the latest data which was AJNR. a series of 12 cases. There was not much technical issues. This article highlights that ischemic complications seem to occur following the overdense coiling at the base of the aneurysm. So not much dense coiling is needed, unlike no, routine coiling with this Trenza device. So access we can use a DAC if we are using a 6F DAC should be needed if you are using 2 micro, and if you are using balloon it should be a 7/4 system DAC should be needed. Sizing is width plus height by 2. We need to see that distal tip should be away from, and 2-3 lips should be there, and all two markers should be visible before detaching. During retrieving, we should be released, and we should keep the micro at the level of the neck before pulling. And next coil can be same micro itself we can use. And for the more than 12 more than 9 aneurysm, we can use second Trenza if favorable anatomy or good adequate filling is possible through that second Trenza device. So we'll move on to the case 2. It's a patient with a 34-year-old female, 7-month postpartum. I presented with sudden onset headache or vomiting, giddiness for the 5 days. Patient, though patient is having only symptoms for 5 days, patient started having some symptoms even more 2 weeks before that, but significant symptom was happened only in the last 5 days. Followed by she presented a sudden onset altered sensorium with a decreased responsiveness. On examination at the arrival at the ER, patient had E3, verbal response was nil, and M5 response was there. She was not obeying commands. Initially, we thought like it may be related to the post seizures, but it was persistent. The symptoms was persistent even for more than 4 hours, and people was 2 mm sluggishly reacting. So this was the MRI. We can see the venous water set in the bilateral coronary radiata and the centrum semi-ovale, and flare wise there is a hyperintensity at the deep venous system and the right transverse sinus, and showing thrombosis. Uh, Venogram source images, you can see the right transverse sinus and the deep venous systems are thrombosed. So there is a both side internal right sinus, internal cerebral vein of Galen was not seen. Right transverse sinus was thrombosed. So this patient, the treatment option initially considered was initially we can do anticoagulation, and if persistent low GCS, we can take for mechanical thrombectomy. Then directly we can do thrombectomy. But in view of very low GCS and deep venous involvement at presentation itself, so we planned for mechanical thrombectomy with thrombolysis. So this was the right IC injection. We are not able to see the internal cerebral vein or vein of Galen. So this was the left side left side IC, and again this side also deep venous system are not seen, and the significant congestion was there at the basal ganglia region. So this was the vertebral vein. Again, we are not able to see the deep venous system. So what we have planned was we used the 8F short seat to access the thrombosed right side system transverse sinus. Under the ultrasound guidance, we access the right side at IJV. Then we use the 8F Cerebase guide catheter over the 125 watt with thermo wire. Then we across this sequentially, and we use the other this tentry wire and micro catheter and uh, thrombolytic agents. So this was the initial run in the right transverse sinus. We can right side at IJV, we can see thrombosed IJV, jugular bulb, sigmoid, and transverse sinus. So we sequentially aspirated the aspirated the clot, and we reached the transverse sinus, and we recanalized the transverse sinus. Then we entered into the straight sinus. There is an acute angle at the vein of Galen. So we used the transition wire to reach that transition as a vein of Galen. Uh, we what there is a significant clot burden was there at the level. So we initially put the stent reaver to with this one is red 72 micro catheter. So it's a red 72 aspiration catheter. With that we do Solumbra technique, followed by we use the micro catheter in the vein of Galen and straight sinus and transverse sinus. We have sequentially given altiplace. Around 12 ml over 12 ml have given overdose. So there is a mild opening was noted. So this was the final run on the IJV. This further clots also was aspirated to the short sheet. So this was the aspirated clots. So post-procedure patient on injection heparin, 1,000 units with the APDT monitoring, and patient on continuous anti-edema measure. On day one CT, there was not much the persistent hyperdensity of the right sinus and intercerebral vein was there, and not much improvement in the GCS. So we have again taken for the patient for DSA. Here we can see there is an even the left side transverse sinus was occluded. Sigmoid and IGV was occluded. So initially we have punctured on the left side and we have sequentially gone through the IJV transverse sinus and we reached this one. Again, right-sided system also was occluded and we wanted to reach the right sinus, which was not possible on the left side. So we reached again, we have to open on the right side to reach the right sinus. This time what we have done is even we gone even more and we gone into the internal cerebral vein on the right side and the left side and we have given altiplace with the aspiration aspiration of the clot with we have given only bolus dose. We given maintenance this continuous infusion we have not given. After this was the final angiogram. We can see there is an establishment of the flow into the internal cerebral vein in the right sinus. So this was the day 2 aspirated clot. So again, patient started continued on injection heparin, 1,000 units per hour for 2 days. There is an improvement in the GCS on the day 3. So patient was extubated and infusion was changed to Clexane, followed by dabigatran. On discharge, patient GCS improved significantly, E4, V4, M6, but still that verbal response is not very adequate, like response is not appropriate. And the patient also had a right-sided mild weakness, which so patient on continuous physiotherapy now. This patient probably ETLG was plus syndrome since patient had two abortions prior and a delay in the conception of conception. Lupus anticoagulant was positive. So repeat testing was waited on 8 to 12 weeks. Then my patient currently on dabigatran and Dimox for the maintenance. So this and similar other case is a 40-year-old female recently diagnosed hypertensive and OC pill for dysfunctional uterine bleeding. Patient had transient weakness of the left upper and lower limb, which was lasted for 15 minutes. Then she was became normal. But patient had severe headache and photophobia and vomiting. So this was the MRI which was done at baseline. Here again, we can see loss of lovoid in the superior sagittal sinus and the convexity veins, which is appear high, showing blooming on GRE images. And the patient also had raised ICP features in the form of perioptic CSF space prominence and CT venogram. You can see the filling defect involving the straight sinus and the right side transverse sigmoid sinus extending into the IGV. Left side system is hypoplastic relatively. And patient also having visual blurring, so visual optic nerve concentrated images, we can see that prominence at a partial empty cell. So initially, patients started on Claxine and Diamox. And day three, patient developed a diplopia in the form of six-nerve palsy. And additionally, she started on oral anticoagulation, and the Diamox dose was increased. But from again on the day five, there is a significant diminution of vision and worsening papilledema was noted, and diplopia also was worsening. So this time we attempted mechanical thrombectomy. So this was the initial angiogram from the right ICA. We can see uh, there is filling defect is there, but clearing of the contrast is there. But the here we can see right transversinus is occluded. There is a left is hypoplastic and significant burden into the anterior circulation. So through the draining into the SOV and the cavernous sinus, that's why patient is having significant raised ACP features. This is on the left side again. It is showing the significant drainage through the anterior venous drainage with a filling defect in the superior sagittal sinus. This patient again we have gone through the occluded right side at IJV. We used the ATEP Cerebase and aspiration catheter and where 125 vertebral catheter for tracking of the aspiration catheter, and we used the directly intrasinus bolus injection of the altiplate. So we reached up to the anterior third of the superior sagittal sinus, and sequentially we have initially we have given the altiplate bolus around 10 ml, and followed from overall its course, and we again aspirated sequentially along its length, and post procedure there is some significant flow was noted without any filling defect. It was nicely opened up, transsinus also opened up. So this was the aspirated clot. So at the discharge, patient showed a significant decrease in the headache, persistent diplopia and blurring of vision was there. Again, patient continued dabigatran and Diamox. Here the etiology was OCP induced. This was the at the time of the discharge, the fundus image which is showing papilledema with the blurring of the disc. This was the images at the 1 month. We can see the significant improvement in the papilledema, except on the right side there is an nasal side there is some blurring, but his patient showed significant improvement in the visual symptoms, and diplopia also decreased. So the indication for the mechanical thrombectomy in the CVT is clinical deterioration in spite of the medical management in the form of a drop in GCS or worsening a new onset of focal neurological deficit or recurrent seizures. And other indication is worsening intracranial hypertension, as in our second case. And the involvement of the deep inner system, it's we can directly take up without any waiting for the medical management. The other thing is contraindication to the systemic anticoagulation. So can